Today we're going to talk about the opioid crisis. Obviously, unless you don't watch TV or you don't have social media, you're aware that there definitely is a problem out there in the state of Tennessee. So today, just some brief objectives. Kind of an old teacher, so I always have to have objectives. There's got to be a point, so bear with me. So we're going to talk about national, state, and local trends as it relates to opioid abuse. We're going to discuss the Tennessee Together Law and how it impacts prescribers, pharmacists, and the community. And then lastly, we're going to talk to you about what are we doing here to help combat the problem as an institution. So this is fentanyl, and it actually came from a drug bust along I-40 that was coming out of Mexico. If you travel to Memphis frequently, right there at exit 25, we used to live in Memphis, so pretty common to come up and down the highway. But if you go to exit 24, 25, they're not sitting there to catch you speeding. They are sitting there with like special heat radars to see if you're passing with drugs in your car. Wow. And so this is actually a drug bust that did occur, and this is enough fentanyl to kill every single resident in the state of Tennessee. So, little quiz. So which venue that you see up here on the screen actually accurately reflects the number of nationwide overdose deaths in 2016? Is it the Grand Ole Opry, Bridgestone Arena, or Nissan Stadium? Who says Grand Ole Opry? Bridgestone Arena? Nissan Stadium? Did y'all get a copy of my slides before we start? It's actually Nissan Stadium. There were enough overdose deaths in the United States to fill it up. And honestly, the United States population makes up 10% of the world. But we take 80% of the world's opiates. So, in case you missed it, it's a big problem. So, you might ask yourself, what am I looking at on this slide? And this essentially tells us what is the likelihood that someone is going to use an opioid medication long term in someone that's never had an opioid to begin with. So you look on the slide on the right, and on the bottom axis, it's days supply for the first opioid prescription. So you hurt yourself, you go to the doctor, and you get a prescription. You can see that the number of pills that they give you is directly related to an increasing probability that you're going to become dependent on opioids. Okay? So when Charles talks about the Tennessee Together law and the new restrictions around prescriptions, you're going to hear him talk about day 3. You only get a 3-day supply. And if you look down here on the left, you can see that's the lowest point that we have to try to minimize opioid addiction. And if you look at the screen, or the graph on the right, number of prescriptions in the first episode of use. So let's go back. Remember, you got hurt, you went to the doctor, you got your first prescription. Let's say you got a 30-day supply. It's a lot of opioids. Well, now there's a good chance that you are dependent on the opioid. Maybe it's just to sleep, to help you sleep a little bit better, or go to sleep a little bit faster. And then you decide, well, I'm still hurting, so I'm going to go back to the doctor and get me another prescription. So you start going up. If you get 2, 3, 4 prescriptions for that same problem, you can see on the right, the probability for increase in long-term use escalates based on the number of prescriptions that you needed for that very first injury that you had, for that very first prescription. So that plays a huge role when we talk about the Opioid Light ER program that Charles is going to talk to you about, and the statewide emphasis that Tennessee Hospital Association is placing on this. Opioid overdose in Tennessee. In 2016, there were 7 deaths per hour in the state. You can see it continues to increase every year. I don't have the 2017 data on here, but this is truly a problem. It escalated from an inpatient in the hospital standpoint when new standards came down that the belief that patients weren't supposed to be in pain. And that's really not true. Our job is to manage your pain. It's not to take your pain away. And trying to take pain away is contributing to the opioid epidemic. This is just some more data. In the state of Tennessee, you can see again, 1,186 deaths were due to opioid overdoses, non-fatal overdoses, outpatient visits. So these are the number of people that overdosed, that came to the ER for that overdose. Over 13,000 people. Of those 13,000 people, 7,000 of them had to be admitted to the hospital. That probably involved some type of rescue medication. I'm sure you've heard it on the news, naloxone. The emergency personnel are starting to carry it so that they can help provide rescue from the overdoses. You also see painkiller prescriptions in the state of Tennessee, 7.6 million prescriptions. I don't know how many people live in the state of Tennessee, but I'm pretty sure it's not 7.6 million people. So you just think about you. Do you have one? I mean, I would say half of you don't, which means that somebody got extra, okay? Some specific data as it relates to Henry County. My understanding is this year there's been one confirmed death from an overdose, possibly one other, but at the time that we made the slides, it was questionable. They were still trying to determine that. I don't know if those of you in the back can see this, but in 2016, Henry County had 6 all-drug overdose, so it doesn't matter. They took a whole bunch of a certain medication and they ended up killing themselves. Of those 6, 4 of them were opioid deaths, okay? And this is per 100,000 persons. Thankfully, in 2016, there were no heroin overdoses. My fear is that's going to change, and Charles is going to talk about that a little bit, because we have patients extremely addicted to opioids, and they need to get their fix. And there aren't as many prescriptions and drugs on the street now, and so they're going to find something else to fulfill the void. You look at non-fatal overdose data. In 2015, Henry County had 89 non-fatal overdose outpatient visits. So 89 people came to the ER and were sent home, as opposed to 33 non-fatals that were admitted to the hospital. Okay. This slide right here is, at first glance, you kind of wonder what are all these, why the changes in colors. Obviously, when you look at the darkest, the burgundy, or as I might like to say, crimson color that you have up here, would be over. This is the 2000 rate per 100 persons, U.S. prescribing rates for opioids. So Henry County falls into the greater than 112.5. In 2015, Henry County was the 5th worst county in the state, with 194 prescriptions per 100 people. In 2016, we moved up to 4th, so we're getting worse. We're trending in the wrong direction. Campbell County, in 2016, it was 187, and Campbell County was number 1, and they were at 195.6. So we are close to being one of the worst counties with the amount of prescription painkillers that we have out there.
Are those legal prescriptions?
Those are legal prescriptions.
Are these based on the pharmacies around here or what the doctors prescribe?
Really, the only way to capture this information is through insurance data. So it would be pulled through pharmacies. So to be honest with you, it's probably falsely low because some people just pay cash for prescriptions. Then you can see here, morphine milligram equivalents. Essentially, we take all opioid prescriptions, we convert them to morphine so that we can get a good quantity on how much we have or how much has been prescribed. You can see that in the dark navy blue, it's all morphine milligram equivalents that were prescribed. It's going down, which is good. But you can see the lighter color blue is morphine milligram equivalents prescribed for pain. And so you ask yourself, well, what's the other reason it's prescribed? Well, it's also prescribed as medication assistant treatment. And that's where you start to see the orange starting to increase. Okay? And what this means is medication assistant treatment is the use of FDA-approved medications in combination with counseling and behavioral therapies to try to get a whole patient approach to treat the entire part of addiction. It's just not physically putting a pill in your mouth while you're addicted. There are many other behaviors that go along with it. And this is what they're trying to do to treat substance use disorders.
I want to talk to you a little bit about some of the changes that are occurring. Of course, this is on national news, local news all the time. The epidemic is really, really at a peak, and we've got to do something to try to get people off of these opiates. So we're looking at ways in the state and federal level to actually do this. So July 1 of this year, there was a law passed that the state of Tennessee implemented, and it's really a lot of responsibility on the pharmacy and really a lot of responsibility on the physician. But you can take the opiates prescriptions, and you know, we're creatures of habit. We get used to writing, physicians, pharmacists, we get used to, you know, every patient gets 60, they get 30, they get 20. That you get to where you're just in a habit of writing that. So we really do a bad job of looking specifically at patients. You know, we're working more like as an assembly line now as people are going through and everybody gets the same 60 or the same 90 or the same 80. And we really need to look at patients. If you've got a patient that's never had narcotics, they really don't need the strongest one, and they really don't need a prescription for 60 or 30 to start out with. We may want to do 15. We may want to do 12. So what the state has implemented is they're going to allow us to do, and a lot of our physicians didn't know about this, so we had to do some education, but a lot of prescriptions, what they're trying to do is cut back on the number of prescriptions that we write, the number of pills that we write for those prescriptions. So what they'll do is they're going to have up to a 3-day opiate prescription or 180 morphine milliequivalents total dosage. You don't have to do anything. So if I'm a physician and I write that prescription and I write it for 3 days and it's below the morphine milliequivalents, I can just write it, patient goes, pharmacy fills it. We still have to check the database. The physician's supposed to check. There's a national database out there now that the minute we fill those prescriptions every night, we send our data to this database. When we call you up, we can see exactly where you got it filled, who the physician was, how many you got, what day you had it filled. So there's a national database out there now so we can track this. So it helps us with patients' physician shopping. If a patient goes to 2 or 3 different physicians and they get one here this week and they're getting one next week, as a pharmacist and a physician, we can pull this database up and we can actually see that now. So if the physician didn't catch it and we see it, sometimes we'll call the physician and say, you know, did you know this patient actually got a prescription about 5 days ago for the same drug, so it's going to make them have too much. Also, insurance companies are beginning to kick back. TennCare's put a 5-day limit. I think you saw in the news recently where like Walgreens or some of the other pharmacies are only doing 5-day fills for narcotics or opiates. So I think insurance companies are fighting back, state and federal government's fighting back, and we're all going to be on our stricter schedule, but this causes problems. But I'll go through this and kind of explain how this new law works. It went into effect July 1st of this year. Due to computer systems, we're really not implementing the full thing until January 1. So they're giving us a little bit of grace period so we can get this implemented and get everybody educated on it. Starting in July of 2019, next year, all controlled substance prescriptions will have to be done electronically. And the reason for this is to fraud. You know, a lot of people will take prescription pads, copy them over. They'll steal prescription pads. We try to keep those locked up here in the hospital, but people will steal those, forge signatures, forge their name. I've even had people call in their own prescription and act like they were the doctor's nurse and get their own prescriptions filled. So There's a lot of way that fraud goes on, and this is a kind of a countermeasure to kind of counteract that. So a physician does surgery on a patient today. They write for a 10-day supply of opiates. Used to in a pharmacy, we couldn't fill it. We had to fill the exact number, but now they're going to allow us to do partials. So if a doctor writes for a 10-day supply, we will only fill a 5-day, and you have to come back and get the other 5 days refilled. You can't come back and get them too soon. Can't get them too early. Yes. The other one you can do is you can write for a 20-day supply of opiates. Say it was a more major surgery, we can still only fill a 10-day supply. You have to come back and get the refill. Everyone has to check the database. Pharmacy, physician has to check the database. We need to do education, make sure an opiate's what that patient needs for their type of surgery that they had. Maybe we could use something else like non-steroidal or something like that. We have to document alternatives for the opiates, and we have to obtain informed consent. The physician does, and we have to include the ICD-10 code on the patient's chart and on the prescription. So if we don't get that on the prescription, if it was a surgery, there's a box to mark surgery, there's a box to mark exempt, and I'll explain exempt here in a minute. But there's a lot more now to do in a prescription for an opiate than there used to be. The other instance over here is if you've been on opiates and you've been on them for a long time, you can do medical necessity. You've tried other treatments, it's failed, you did 30 days, you get, the opiate seems to be working, so you write medical necessity on there, you put the ICD-10 code on there, and then we can do a 30-day supply. And then there's also patients that are exempt, or would be like our nursing home patients listed down here below, palliative care, receiving hospice care, diagnosis of sickle cell, licensed facility, pain management specialist, a 90-day patients treated for opiates for 90 days, and then patients are treated for methadone clinics, and then patients who have suffered burns or physical trauma, you can do more, but you have to put on there exempt. They're exempt from this, and you have to put the ICD-10 code that matches being exempt. One thing that we treat all these patients. We have our nursing home, we have hospice that we treat, so we see every type of these prescriptions. If a physician leaves something off, we'll try to call and remind them. We've done a pretty good job here of putting on our prescriptions a spot for the ICD-10 codes, a spot for the exempt, and a spot for the surgery. I think when they go to electronic prescriptions, if you don't have those filled in, it'll be a hard stop, and you won't be able to transmit that prescription until you complete that part of it. So don't get mad at your pharmacist when they come and they tell you that, we can only do half this prescription, you're going to have to come back. I mean, this is law. This is what we have to. And I just had a state board inspection 2 days ago. He went through every Schedule II prescription and checked for ICD-10, the surgery, and exempt. And if I didn't have it on there, I had to call the physician, he said, and make sure that we get it on there. The best way we tell our physicians is to put that code in your phone for post-surgical pain. Put it in your phone, and you've got the code with you at all times. So what we try to do is educate our physicians and our staff here at the hospital. We try to educate the patients. I think pharmacy plays a big role now. When we fill prescriptions, we tell the patient about the addiction. We tell the patient about putting them in a safe place. Don't put them in your medicine cabinet. You'll be surprised how many of your company come in your house now. And they go to your bathroom and they go through your medicine cabinet and they steal your pills. Addiction is a big problem. One of the problems I see when we start enforcing this and start doing this, we got a lot of people out there that are addicted. And what are they going to do? They're either going to steal it, they got to have the high. The first time you take probably crack cocaine or you take meth is the best high you'll ever get. After that, you're chasing that same high again. You never get that same high. It takes more and more. So patients, they're going to take more and more. As we take these away, these people are addicted, and we start taking these away, they're going to go and get heroin. And the problem with heroin now, it's coming in from China and it's laced with fentanyl. And fentanyl will kill you quickly. It doesn't take a very big dose of fentanyl before you'll stop breathing. And that's the reason we started putting in our ambulances and law enforcement, and even people that, if you have a relative that you know that is addicted to something, the best thing you can do for them is get you an amp of Narcan or get you a Narcan syringe and keep it with you, because at some point in time they're probably going to overdose. and it's not meaning to, they're buying drugs off the street and they don't know how they're compounded and how they're made. And we have numerous ones that you'll see. We had, several months ago, there was some, I think, crack or something in town that was made and it wasn't made properly, and a lot of patients were coming into the ER that were having problems. And, you know, if someone's compounding this, you don't know what's made from, that fentanyl will definitely mess you up quickly. So our law enforcement in town, our highway patrolmen, our ambulances, they actually have Narcan. The problem is we create a shortage for Narcan because everybody was buying it then, and now the price has jumped up. And it's getting hard to afford Narcan out there.
This region actually has a road coordinator, a regional overdose prevention specialist,
Mm-hmm.
and if you call her, she can give you Narcan for free.
Mm-hmm. Yeah, I was going to mention that. I went to a thing several months back with some legislators, but I'll mention some of the programs that are out there and some of the things that you can do. But this is kind of our new prescription policy, and I do think it's going to create some problems because we're taking drugs away from people that they've been used to getting. And they're going to get them somewhere, whether they're going to get them from you or they're going to get them from other family members. A lot of patients use this to supplement their income. A lot of patients that have been on prescription drugs for a long time, they may not need but half of them. So they can sell these things for anywhere from $5 to $50 probably on the street. So they supplement their income. If you're a low income person and you've got access to these, that we've actually seen some sold out in our parking lot out here and turn people in for it. Yeah, it happens every day. You'd be surprised. To give you how small a percent, a lot of our physicians write on there, they write the script and then they write for 30 and they say for 3 days. Well, just because you write for 3 days doesn't mean it's for 3 days when you go by the new law. If it is for 3 days or less, these are the common ones we see in the hospital are Lortab and oxycodone. So if they write for 30 and they do 1 to 2 tablets every 4 hours, that's 12 a day, that's 36. But if they write for 36 of the 7.5, they can only get 24. You have to fill it as a partial. You have to fill out everything, surgery, exempt, non-exempt. Same way with Percocet, we use a lot of it. Well, if they write for 30 of 5s, that's too much. That's not a 3-day supply, so we have to call a physician and get all that filled in. I actually supplied this for most of the physicians' offices, but we still have some physicians that write for 3 days because 12 times, 6 or 6 tablets, let's say 2 tablets, 12 a day, times 3 days is 36, and they think they can write for 36 for all these, but you can't. So I've sent that out to the offices, and if any of you work at offices and stuff and you need a copy of this, we have a copy of it. It came out from the state. So you can see the 10-day, it tells you how many you can write for, the 20 days, and then the 30 days. But if you write for 168, but you write for this drink, you can only get 85. Even though it looks like it's just for 20 days. So as pharmacists, when we're filling that, it's a lot more complicated. You have to think about everything that you have to do and everything you have to check. So one thing we're trying to do here at the hospital is implement opiate-like an opiate-like pilot thing in the ER for our physicians down there. With all this narcotic problem that we see, it's becoming very, very hard for physicians to become pain clinic specialists. They've changed the rules. They've changed their qualifications to be pains. We've had 21 clinics already closed from one company on pain management. So where are these patients going to get their medications? They're going to come to our ER. They're out, they don't have any, they're hurting, they're going to come to the ER. So we're having to put in a opiate line emergency department. And what we're trying to work with our physicians is give them alternatives. I don't know if that's on the next slide, I believe it is. But our goal is to reduce the opiates administered by 20% in our ER. We did a baseline through March or April, I believe it was, to see how many meal equivalents we were doing in April. And our goal is to reduce that by 20% in our ER. And what that means is working with our physicians and giving them alternatives to opiates. The alternatives is to give them like for headache, migraines, musculoskeletal pain, chronic abdomen pain, extreme fracture and joint dislocation, and renal colic pain. As pharmacists, we are working with other hospitals and coming up with different drugs, whether it be non-steroidals, it be steroids, it be different types of medications that we can use to give our physicians a list, and we post that down in our ER for those types of pains, and that's what we're really looking for. We've tried to eliminate Demerol from our whole hospital. Demerol is a very unsafe drug when it comes to the elderly patients. You see a lot of patients hallucinate on Demerol. It's not metabolized well, it's on the Beard's list. So some of these drugs we're trying to eliminate, but we're trying to give our physicians a different set of drugs that they possibly can use first before going to opiates as a first choice. We want to come up with a non-opiate approach for pain relief for certain conditions. Our goal is to utilize non-opiates approach as a first-line therapy and educate our patients. All opiates do is it fakes the body out that you're not hurting. It's not doing anything to fix the problem. All it's doing is helping you fake the body out that I'm not hurting. It's what the opiates really do. You don't fix the problem. If you're having back pain, and some of the things we're doing here at the hospital with back pain is we're actually doing some injections now, like spine and back injections, and trying to get away from some of the opiates and get people relief by giving them some drugs for back pain to manage their back pain better than trying to put them on opiates, because it doesn't take but about 30 days and you can get addicted to opiates really quick. And let's see what else. Discuss realistic pain management goals and discuss addiction and potential side effects of opiates. Education plays a big part. That's something I think we do a pretty good job here at the window. We tell people, look, go home, first day or two, you're going to be hurting. You may take several pain meds, but after that, you need to start weaning yourself off. Maybe alternating with ibuprofen, alternating with Tylenol, but a lot of these have Tylenol, so we caution them on taking too much Tylenol. When you're on these and you're taking 12 a day or 6 a day, you're getting a lot of Tylenol. So don't take any Tylenol products anytime you're taking Percocet or hydrocodone. Warm blankets, ice, dim lights. There's a lot of things you can do to help with pain besides take a opiate. So we try to educate on that and give them an alternate approach in risk management of opiates. And community education, social media, and educational pamphlets are tried to be given out. So another thing that took effect this year in July was gabapentin. Gabapentin went on Schedule 5. And a lot of people take gabapentin for neuropathic pain. Excuse me on that. But it's for nerve-ending pain. A lot of people are diabetics. A lot of people that have legs amputated or something like that, they still think they have pain in those areas. So it's a widely prescribed drug, but it went to a Schedule 5. And people ask, well, why did my drug go to a Schedule 5? Well, we found out on the street that you could take gabapentin along with your Lortab and get that better euphoria effect from taking both of those in combination. And when people start taking Lortab, they can take 1 or 2. People who are taking Lortab now, they've been on it for a while, they're taking 5 to 10 at one time to get the high. So basically they're taking way too much for the liver, and they're actually damaging their liver by taking so much Tylenol in these products. So that's something we really need to work on. We actually have a 300,000 milligram limit in the hospital of the amount of Tylenol they can take. So we really monitor that to make sure they're not. But that's one thing we do educate on a lot.